This short video is designed to introduce behavioural therapy as a counselling approach in nutrition and dietetic practice. We will start with an introduction to the historical and theoretical background of behavioural therapy, then explore the use of behavioural therapy in dietetic practice through an interview with an accredited practicing dietitian. Finally, we will present the findings of a literature review looking at the applications and effectiveness of behavioural therapy as a tool in nutrition interventions. Behavioural therapy, also known as behavioural modification, was developed in part by Pavlov, Skinner, Wolpe, Thorndike and Bandura. It was based on the psychological theory of behaviourism, which proposes that individuals learn all behaviour through interaction with their environment and are passively conditioned to respond in a certain way. Thus, the application of learning theories is used to modify behaviour. Behavioural therapy can be applied with clinical patients and to improve behaviours around rehabilitation and education and for prevention of atypical behaviours. In clinical settings, it has been found to be particularly effective on mental health patients, mending relationships between couples, chronic pain, stress-related behavioural problems, anorexia and obesity. In 1953, Skinner revolutionised behavioural therapy by developing radical behaviourism and introducing operant conditioning to explain the link between the environmental stimulation and the automatic response. Here, Skinner demonstrates how he used operant conditioning to train a pigeon to turn in a circle by rewarding the desired behaviour with food.
This bird has been already conditioned to eat when the magazine sounds and the light flashes. And then I reinforce that movement.
He used a similar technique to teach these pigeons to play ping pong by rewarding each of the birds when they managed to push the ball past the other. After many years of development and input from various contributors, behavioural therapy progressed to cognitive behavioural therapy. In nutrition-based behavioural therapy, classical conditioning pinpoints and removes the stimuli, environmental or internal cues that affect food behaviour. Clients may be encouraged to recognise and eliminate cues. For example, instead of sitting in front of the television on the couch, which stimulates eating unhealthy snacks, changing the activity to running eliminates the stimulus for this undesired behaviour. Operant conditioning focuses on behaviour that is altered by the outcome. Thus, to change food behaviour, the outcome is usually presented as desirable and positive. For example, the reduction of body weight and slimming down of physical body can be the reward for achieving the goal of replacing an excessive kilojoule intake and unhealthy diet with a low kilojoule intake and healthier diet. Modelling is observational learning through listening, watching and reading food behaviours, learning from others' experiences. For example, in the documentary Copy Kids, by watching a video of a toddler who is enjoying eating broccoli, the toddler watching the video copies the food behaviour. Nutrition counselling integrates these strategies to achieve goal setting, self-monitoring and relapse prevention. Behavioural therapy counselling is used to encourage the replacement of undesirable learned behaviours with new desirable learned behaviours. It is different from other counselling approaches as it is action-based, present-focused and its primary goal is changing the environment to facilitate behaviour change. To learn more about the use of behavioural therapy in dietetic practice, we spoke to accredited practicing dietitian Anna Vassallo, who has worked for more than 15 years across hospital, community health and academic settings. We asked Anna to describe her understanding of behavioural therapy.
Behavioural therapy, okay. Well, with behavioural therapy, it's very much working with people for them to actually take control, to modify their own behaviour.
Using discretionary food intake as an example, Anna emphasised that clients' self-awareness of the link between environmental stimulus and a resulting action is needed before any meaningful behaviour change can occur.
Because I would suggest that most people don't join the dots in relation to if it's there, then it's available for you to eat it. And even just saying, if we just talk about what you think is reasonable in terms of how many extras, do we use the word extras, discretionary food, whatever you want to call them, you think you want to work towards limiting your discretionary foods too, then maybe thinking about, well, maybe we only put that amount in your pantry or have that available to you. I think sometimes unless you say that to people, they don't join the dots. But it also comes back to that needs to be something that they want to be working on and working towards.
Anna told us about her time working with clients who were diagnosed with severe mental illness and how she used behavioural therapy to help manage their caffeine intake.
So these are people who have been diagnosed with schizoaffective disorder, paranoia, whatever. Like this isn't just your usual depression and anxiety. This is much more extreme stuff. So always, the clients that I would see would be very heavily medicated. And the side effects associated with a lot of these antipsychotic medication is extreme thirst and extreme hunger, and either sleeping all day and completely being out of whack in terms of a rhythm in life, just in their day, or not sleeping at all. So in terms of applying behavioural therapy, so for instance, this happened a lot, say I had a particular client who was thirsty all the time, and would always, the habit would be to drink soft drink, particularly say caffeinated, say Coke. And the other thing is a lot of these were smokers, and often with a cigarette would go a cup of coffee. So we would have someone who is saying they're struggling with sleep, yet having 8 litres of Coke a day and 16 coffees a day. So often they wouldn't see the connection between what's going on and just the fact their dietary choices that they were making each day. So we would spend some time talking about that. The fact that, caffeine is a stimulant, as is Coke, and there is caffeine in Coke, which is also a stimulant. And perhaps there potentially could be one having an impact on the other. But, I would say to them, don't take my word for it. Do you want to give it a go? And we would do that together.
We asked Anna if she could define some of the advantages and disadvantages of using behavioural therapy in practice.
Well, the advantages is that it is very much patient-driven. So the things that you are providing your patient with support with are things that they're actually recognising that they actually want to do something about. So in terms of the advantages, I think it's very much patient or person-centred, which I think is absolutely the gold standard with any sort of relationships between a clinician and a person. That's a huge advantage. And the clinician is really just coming along for the ride and providing some support, but it's really the patient that's doing all the work. The disadvantage with that, I guess, is that they might choose not to do any work, but you know what? That's actually got to be okay, because that's okay. That's okay. If we deal with adults make decisions. I think you're doing your role by providing the support network and providing the guidance and steering where you think they possibly be supporting better decisions, but ultimately it's up to them.
Anna stressed to us that behavioural therapy can be used in consultations with all kinds of people and is rarely used on its own.
To be honest, I think behavioural, and I know you guys learn it as a concrete theory, then you move on to the next and the next. Yeah. It's not about this theory being particularly beneficial and this one not. It's about they all kind of integrate and become one big way of how you relate to people.
Finally, Anna explained that determining the best counselling approach, whether behavioural therapy or otherwise, depends largely on the clinician's ability to anticipate what will work best for the client and to tailor the approach accordingly.
I don't think that I would walk in and I would start talking to you as a potential client and say, I'm using this method. It just doesn't work like that. I think it's about you just need to pick up on the cues, read the environment, and go with what you think will work. And you might get it wrong sometimes, and that's okay. And then you might have to backtrack a bit, and then you will just try something else until you start connecting with your patient. I don't know if you know what's going to work until you throw a few things out there. I think this is life. I think this is life in every regard when you're dealing with people.
Considering the lack of research into the use of behavioural therapy by dietitians, the aim of this review was to find and examine articles on the application and effectiveness of behavioural therapy in nutrition and diet interventions. 2 investigators were involved in systematic searches of 3 databases: Medline, CINAHL, and Cochrane. One investigator then searched the Journal of Human Nutrition and Dietetics. The searches were limited to entries that were peer-reviewed, in English, and published within the last 15 years. These search terms were specified, with truncations and wildcards used where required. Boolean operators and or were used to refine these searches. The truncated search term behaviour therapy was used to exclude articles containing cognitive behavioural therapy from being retrieved. Six studies were found which matched the inclusion criteria, which were reviewed and analysed by 2 investigators. This study from Avenel et al. In 2004 determined that combining behavioural therapy and dietary advice can improve long-term weight loss, and quoted statistics showing the importance of counselling techniques like behavioural therapy in modifying diet behaviours and increasing life expectancy. Stewart et al. In 2008 found that dietitians delivering behavioural therapy were well received compared to those who didn't. Parents who had taken part in behavioural change techniques for their children applauded the process, calling it child-friendly, and spoke of forming a partnership. A recent study by Schlaff and colleagues found that nutrition-focused behavioural interventions significantly increased fruit and vegetable consumption and was associated with improvements in fat and fibre-related behaviours. They described behavioural therapy as low-cost and accessible, with the potential to affect population health significantly. Research by Sullivan et al. In 2012 used behavioural intervention to successfully modify the diets of children with constipation for 3 months compared to standard interventions. They also pointed out that dietary intervention alone is not an effective treatment. Bellantani et al. In 2008 found that behavioural therapy was reported to increase weight loss and improve liver histology in non-alcoholic fatty liver disease patients, and stressed the importance of multidisciplinary teams including dietitians, psychologists, and physical activity supervisors caring for patients. Finally, Whitehead explained that good communication skills for behaviour change leads to greater patient satisfaction, which in turn leads to greater compliance and adherence to decisions made within dietetic consultations. Whitehead's paper emphasised that dietitians are required to communicate effectively and that they have an important role in supporting patients to change diet-related behaviours. The studies reviewed varied in outcome measures, description and implementation of the behavioural therapy interventions, as well as the strategies used to promote behaviour change. Overall, the literature review showed that behavioural therapy was an effective technique for achieving better health outcomes associated with modification to diet. Maintenance was also shown to be increased with the use of this strategy. In regards to dietetic use of behavioural therapy, patients perceived it to be helpful, especially when the behavioural therapy was communicated appropriately. Client-patient rapport was important in the process of behavioural therapy and was shown to increase patient compliance to decisions made in consultations. In this video, we have explored behavioural therapy from 3 different perspectives: the historical and theoretical background, its use in dietetic practice, and a review of the research into applications and effectiveness. We have found that from a theoretical point of view, behavioural therapy is action-based, present-focused, and aims to change the environment to facilitate behaviour change. In dietetic practice, behavioural therapy is often used in conjunction with other forms of counselling and requires self-awareness on the part of the client and support and knowledge on the part of the dietitian. Finally, although recent research into the application of behavioural therapy in nutrition is limited, the available literature suggests that behavioural therapy is an effective technique for achieving better health outcomes with dietary modification, especially when clinician-patient rapport is well established.